Alright, so Road 250, today we're going to go over some genital embryology and disorders of sexual development. Alright, so in genital embryology, we all know that before we differentiate into male versus female, we have ambiguous internal embryologic organs that are just indifferent gonad. Oh, wait, there we go. Indifferent gonads, like we see here, and we have two different pathways which we can go. We either have the paramesonephric duct or the mesonephric duct, and so we also got this pink structure here called the gubernaculum that helps with anchoring and moving these gonads into the proper position where they will eventually end up. And then we got this urogenital sinus that is going to come in later as part of the final sexual organ development. So if we have no androgens, we're going to end up with a female person. So basically a female is the default. And if we have certain hormones that arise from the testes, then we will end up with a male human. And we're going to go over that more in depth. So if we end up with a testy, then we will see the degeneration of the paramesonephric ducts, and the mesonephric ducts, which is seen here, are going to predominate, and vice versa. If we end up in the default, no androgens, then we will see degeneration of the mesonephric ducts, and the paramesonephric ducts will predominate. And we will go over all those create now. Okay, so paramesonephric ducts are for females, and the mesonephric ducts are for males. So we start out with these undifferentiated gonads, and so I'll start off with the default female here in pink on the right. So if we have an XX female, we're going to end up with ovaries. The ovaries secrete estradiol, which will eventually create the external female genitalia, which include the clitoris, the labia, and the distal end of the vagina. And like we just saw on the previous slide, with ovaries, we're going to see the degeneration of the mesonephric ducts, so those go bye-bye, and we continue on with the paramesonephric or Mullerian ducts. So they go on to create the internal female organs, which include the fallopian tubes, uterus, and proximal vagina. And this is really important to remember. So this, again, is the default. However, if we end up with testes, before we go there, if a fetus ends up with an XY chromosome, within the Y there is the SRY gene. That gene codes for our testes. So what's important about the testes is that they they create and are made up of two different types of cells which secrete different things. First off, we have the Leydig cells, and these guys secrete testosterone. So testosterone has two jobs. The first job is, like we saw in the previous slide, with testes, we're going to have the degeneration of the paramesonephric or Mullerian ducts, and we're going to have the continuation of the mesonephric or Wolffian ducts. Now, these are going to create the internal male genitalia, which is the seminal vesicle, epididymis, ejaculatory ducts, and the ductus deferens. And I always use the mnemonic SEED to remember those for seminal vesicle, epididymis, ejaculatory duct, and ductus deferens. So these make the internal male organs. Now, testosterone's second job is this second pathway here, where, I shouldn't have drawn over that, but anyways. So it's going to go to the second pathway here, where it's going to interact with 5-alpha reductase. 5-alpha reductase turns testosterone into its super potent cousin, dihydrotestosterone. Now, DHT's job is to make the external male genitalia, and remember the mnemonic PSP for penis, scrotum, prostate. Penis, scrotum, prostate. So the other job of the testes, on top of making the internal and external male sexual organs, is that we've got the Sertoli cells within the testes, which make Mullerian inhibitory factor. This guy is super key because since females are the default, we need something to stop the paramesonephric ducts from continuing. And that's what Mullerian inhibitory factor does. It stops the creation of the fallopian tubes, uterus, and proximal vagina. Again, this is very important to remember about the Mullerian ducts, because without Mullerian inhibitory factor, these guys will continue being made. So again, the reason we need Mullerian inhibitory factor is because this whole area here is default setting. So we need something to turn off and stop the default so that this can happen instead. Does this chart make sense to everyone? Any questions on this guy? Okay. So, we're just talking about the organs that are made based on what hormones act on them. So now this is going to be the male-female genital homologs based on their embryological derivatives and what they will become. So we can play this little game. So DHT, like we said, is the male superpotent testosterone, which is going to change up all of these items in the middle. And estrogen for women is going to differentiate into the female external and internal. So synthesize into
penis and clitoris, but certain parts of it specifically more that I forgot.
So we got the glans penis, and then the corpus cavernosum and spongiosum. So essentially the meat of the penis, if you will. And then glans clitoris and vestibular bulbs. How about the urogenital sinus? That was that little organ at the bottom of the first slide that we saw. Well, the origin of organs that we saw at the bottom of the first slide. That's okay. These are more internal organs. So they're going to create for men the bulbourethral glands or glands of Cowper. And for females, the greater vestibular glands or the Bartholin's glands. So the bulbourethral glands on males are responsible for helping help with the creating ejaculate, and the Bartholin's glands apparently is also associated with lubrication of the vagina, and these are normally in the 4 o'clock and 7 o'clock position on the female external introitus. So the urogenital sinus can also make the prostate gland in males, not can, does make the prostate gland in males, and then the urethral and paraurethral glands of Skene's, which I believe are typically at the opposite ends of the, oh, that's not the urethra, that's a little lower. Well, okay, so here and here, bad. So the urogenital folds become the ventral shaft of the penis, or the urethra, and for the women, it becomes the labia minora, as we can see here, and the urethra. And then labial scrotal swelling, what does that become?
The scrotum and the labia majora.
Right. So the takeaway from here is that there are a few pathologies that like to be tested on. So for men, a disorder of which of these can cause hypospadias?
The urethra?
folds.
What is the,
Ventral gland.
or what is the
urogenital fold?
There you go, the urogenital fold. And if it was epispadias, what part of the penis is affected in epispadias?
Urethra? Well, we just...
The dorsal side.
Right, so which of these...
Oh, the genital tubercle?
Right, genital tubercle, specifically, most likely, corpus cavernosum and spongiosum. Again, it's the meat of it. So then the other takeaway from this would be that if you don't have either Mullerian inhibitory factor or DHT, you're going to end up with a child born with something like this undifferentiated, ambiguous genitalia, where it's kind of a penis, kind of a clitoris. It's not necessarily a scrotum, but not really lips. So this is where it is important to understand where the embryology comes from, because this is where the test questions come. Because they're just going to tell you, oh, ambiguous genitalia, and then they'll give you some other clue. Oh, is it Mullerian inhibitory factor? Is it a reductase deficiency? So these are the takeaways from this. And honestly, the only questions that I have seen personally have been urogenital fold, genital tubercle, mostly about epispadias, and I think I may have seen a prostate embryological question. Because labial scrotal sweating, that's you hope you get that question because that's too fucking easy. And then the glands are, kind of, well, not as often tested in my opinion. Any questions on this slide? Okay. So we kind of saw in that first slide the descent of the testes and ovaries, and they're normally done by the gubernaculum, that pink thing. So the gubernaculum helps with the descent and the journey of the testes from the abdomen down into the scrotum, and it anchors the testes in there. And then for females, the ovarian and round ligaments are the remnants of the gubernaculum. So if a man had an issue with the gubernaculum, what kind of pathology might they be seen with?
Undescended testes.
What do we call that? The fancy term for it. But what if I said the fancy term for the testicle is hiding? Hiding.
Like cryptorchid? Yeah, cryptorchidism.
Cryptorchidism, right. So cryptorchidism can either be congenital, like Divya said, it just never descended, or it could be, it could just, kind of rise up on its own if the cremasteric reflex and cremasteric muscle is contracting and there's no anchor to bring it back down into the scrotum. It could just keep on ascending higher up. So then we also have the processus vaginalis, which is a part of the spermatic cord. And it helps with the evagination of the peritoneum when we have the testes, again, evaginating from the abdominal wall into the scrotum. So for men, it forms the tunica vaginalis, and then in females, it's obliterated. So again, what pathology might we see if there is a patent processus vaginalis.
Wait, what was the question about patent processus vaginalis?
What pathology might we
It's
see?
hernias, specifically
Hydrocele.
indirect. Correct.
Hydrocele.
Yes, hydrocele.
Never mind.
So if you have a patent process vaginalis, you're going to have a connection from the abdominal cavity into the scrotum, and so you'll have fluid that has a communicating hydrocele. Now, would this be a transilluminating scrotal swelling, or a non-transilluminating scrotal swelling?
Transilluminating.
Yes, it would be positive for transillumination because it's a clear fluid. Make sense?
Mm-hmm.
Okay. Oh, and here's just a picture of the gubernaculum, this pink guy. So if you go the testes route, this gubernaculum is attached here to the testes, and it helps with the descent here through the abdominal wall into the scrotal sac. Okay, which of the following is the adult male counterpart of the genital tubercle in the embryo?
B.
Glenn's penis is correct. What if I said urogenital sinus?
A. Or C.
Nice. Yes. A or C, correct? What if I said urogenital folds?
E.
E.
Which one?
E.
E for elephant.
Yes, urogenital folds. And this is the labial scrotal swelling. Very good. Okay, so we're going to be diagnosing disorders of sexual hormones, and we're going to be using this image here to understand each of these disorders. So just to quickly go over the hypothalamic pituitary gonadal axis, we got the hypothalamus, which secretes gonadotropin releasing hormone into the anterior pituitary, which releases LH and FSH. So LH's job is to activate Leydig cells to secrete testosterone, which is supposed to hit its target organ and then do what it does. Whereas FSH is supposed to stimulate Sertoli cells, which stimulates inhibin B and androgen binding protein. Now, testosterone is its own feedback mechanism at LH and the hypothalamus, and inhibin B is its own feedback mechanism on FSH. So that's the nitty-gritty, and we'll go into some of these disorders now. So if we have elevated testosterone and elevated LH, the diagnosis is going to be a defective androgen receptor. Now what that means is that if our target organ is not working, then testosterone is going to keep getting secreted, and LH is going to keep getting secreted because the target organ is not getting the signal that it needs, so it's never being stimulated. Okay? So that is how that particular diagnosis will be made. If you have high testosterone and low LH, then your diagnosis is going to be a testosterone secreting tumor or exogenous steroids. And the reason for that is because if you have high testosterone being cranked out, LH is decreased, so we don't have LH, but we have a lot of testosterone. Sorry, I drew that wrong. So LH is decreased, but somehow we're still getting testosterone stimulated here, but it can't be coming from here that means we've got T that is coming in either from some kind of tumor that's secreting testosterone, or we've got a guy that's a gym rat and he's injecting himself with some T. Because we've got this extra testosterone that is able to turn off LH, yet it is still able to target the end organ. So, we got high T, low LH, we've got an external source of testosterone. If we've got low testosterone and high LH, that means we've got what's called primary hypogonadism, which means essentially that that the gonads themselves are not able to synthesize testosterone. So essentially, the Leydig cells within the testes are goofed up. So LH keeps churning out like crazy, but there's no testosterone production because the Leydig cells themselves are not able to get stimulated and do what they're supposed to do. So that is primary hypogonadism, and I'll come back to this one in a second here. If you've got decreased testosterone and decreased LH, this is what's known as hypogonadotrophic hypogonadism. And that is essentially either a pituitary issue or a hypothalamic issue, because you have no gonads, so hypogonadotropic hypogonadism. Okay? Hypogonadism. So going back to this, hypogonad could actually also be called hypergonadotropic hypogonadism. And this could also be called secondary hypogonadism. And I'm saying that because, going back here, primary, you've got high LH and low testosterone. So it could be hypergonadotropic hypogonads. The gonads aren't working, but the gonadotropes, the ones that stimulate the gonads, those are still working. So that's why hypogonad and hypogonadotropic, you've got an issue that is higher up. Does all of these make sense when you look at this graph or this chart, this image, whatever?
Mm-hmm. Just to clarify, so for the feedback inhibition to happen from testosterone, it has to come from the end organ.
Are you looking at the first line here?
Yeah. So like.
Well, I think it has to do with the fact that if you're not getting the end result, there's got to be some kind of feedback mechanism to if your end organ, essentially the testes, aren't getting made, or not even that, your sweat glands or your hair follicles, if they're not growing and there's something wrong, then you're going to have an excess stimulation of LH because it's going to, something else probably higher up in the hypothalamus, it might stimulate, hey, let's get some testosterone going. I don't have that answer for you necessarily. I just, I would think that if there is no end organ result, then LH is going to continue cranking out. Because here, you have an end organ result. The end organ can get stimulated, so LH is turned off.
Yeah, I guess on that diagram, it shows just testosterone doing the feedback inhibition, but for the secreting tumor, you have decreased LH, so there is feedback, but for just the receptor problem, even though you still have increased testosterone, you don't have that feedback. So I think maybe it has to be from the whatever end organ thing going on,
Could be.
if that makes sense.
No, it does, because that was the one thing I was hoping someone wouldn't ask when I was looking over this, because I knew I didn't have the answer for it.
Okay. It's just that the line off of testosterone makes it a little confusing, but
Well, and we're about to go over examples of most of these, so we can discuss that a little further. If I had to guess, I would think that it's, even though our body says, "Oh, we got enough testosterone, let's turn off LH," but hang on, we're not getting facial hair, we're not getting a vas deferens and ejaculatory ducts. Like, we are not getting the organs and the results that we want. So we got to keep cranking this out. But no, good question. I'm sorry, I don't know the answer for you. Okay. If the androgen receptor is dysfunctional, what would the levels of LH and testosterone be?
increased for both.
Yes, both increased. And we just went over why it doesn't make sense. Okay, so going over some specific diseases associated with this. We've got placental aromatase deficiency. So this is where you can't make estrogen from testosterone. And so in the theca and granulosa cells within a follicle, we have aromatase, which can turn androstenedione, which is a cousin of testosterone, into estrone, which is the type of estrogen we normally get from fat, and that is converted peripherally into estrogen. Now, the issue is, if aromatase is dysfunctional, you're going to get a buildup of androstenedione, and peripherally, if that doesn't get turned into estrone, then it is going to turn into testosterone. So you're going to have an excess of T's flying around in a female, and you're going to get a masculinization of a girl. So, just like we talked about, you're going to get ambiguous genitalia, because even though her external organs are supposed to be labia majora, clitoris, vagina, it's going to be enlarged to the point where the labia majora might start looking a little bit like a scrotum, and the clitoris might start looking like a small penis. So this is how the the ambiguous nature of female genitalia can arise, because you have increased testosterone. Right there, increased testosterone, interesting down. And a clue that will separate this from other disorders of sexual development is that you'll get maternal virilization during pregnancy. So, sorry, a baby's being made, but mom is going to be the one that, while baby is in there, mom's going to be complaining, "Oh man, my arms are getting hairy, my sweat glands are really acting up, I smell like a guy, my voice is deepening." So this is the key to differentiate on a test question between other, when they just say, "Oh, ambiguous genitalia," and you're like, "Well, fuck, dude, that could be a bunch of things." This is the key right here, where mom bitches about being hairy and smelly and sounding like, Ving Rhames. Any questions? Sorry, I don't know why my voice is cramping out. Okay. Androgen sensitivity syndrome is a board favorite. So, in this one, you have testes present, but female external phenotype. And this is the one that you were talking about, Davia, where the end organ, the testosterone receptors do not work. So we got testes cranking out LH, cranking out testosterone, but the end organ isn't working. So we're going to have a lot of T just hanging around everywhere. If we have, okay, so we got testes, but we don't have the end organs working, we're not going to get these, we're not going to get the external and internal male. Oh, sorry, actually, I should have gone this way. But we won't get both either. We're not going to get these because they are not, again, the end organ is not working. So it's not that they don't have a penis, scrotum, prostate, or, the internal organs. It's just that, well, default's going to take over, and it's just going to go with whatever it can work with. So there are two pathologies that are very similar, and it's androgen insensitivity syndrome and Mullerian agenesis. And so really the main difference here externally that you can see is that there's no axillary or pubic hair in AIS, and there is in Mullerian agenesis. So why is that? So in androgen insensitivity syndrome, we have an external appearing female, but she is 46XY. So she has testes. They have testes. So they can crank out as much testosterone as they want. But everything past here does not work. So they do not have any external male genitalia or internal genitalia of any kind. So they are going to go with the default setting. Whereas in Mullerian agenesis, there is an error in the Mullerian ducts somewhere down the line. That has nothing to do with testes. And they do not end up with the internal female genitalia, fallopian tubes, uterus, and proximal vagina. So what you'll see in a patient with Mullerian agenesis is they'll have normal external genitalia, but if you were to do a speculum exam, they will have a short, closed-off vagina with no cervix. So that's another key. Is a young woman who might present saying that she has never, this is a source of primary amenorrhea. She might say she's never had her period, she's already 16 years old, and it really hurts when she has sex. Well, because she has a very short vagina and no clitoris and no internal organs. For both of these, you're going to have no internal sexual organs. So, in androgen insensitivity syndrome, there is a risk of malignancy because this person has testes. So, you want to do a gonadectomy to prevent them from getting testicular cancer, but you want to wait until after puberty because the testosterone in the testes is what will get converted into estrogen peripherally and will help the woman develop what small secondary sexual characteristics that she can, such as growth, so that she grows tall, and so that she can get some breast development. Because if you cut those out early, she's going to be short and, look like a child her whole life. And then Mullerian agenesis is just a female whose Mullerian ducts did not get synthesized. And here's a bunch of people that are women that have androgen sensitivity syndrome. No hair. Okay, 5-alpha reductase deficiency. So this is testosterone, and that is dihydrotestosterone. And in the middle, we have 5-alpha reductase to make that happen. So, like we already talked about, 5-alpha reductase makes dihydrotestosterone, which is responsible for PSP, penis, scrotum, and prostate, the external male genital organs. So if we have a problem with 5-alpha reductase, we don't get that PSP. So this person will have internal male organs, but ambiguous genitalia externally. So this is going to be phenotypically a girl who starts developing a phallus at puberty, and that's because even though that they don't get DHT during puberty, there's a spike in testosterone, and because there's excess T's in general, that can spike a somewhat development of the penis, scrotum, and prostate. So this has also been called the penis at 12 phenomenon. So at puberty, they'll develop testes, a deep voice, and hair growth. So I like to remember this one because I remember penis at 12, and this has a 5 in it, so I just remember there are numbers in both of those, and that's how I remember that one. Works that way. So patients with androgen insensitivity syndrome lack a uterus, upper third of the vagina, cervix, and fallopian tubes. The presence of what hormone is responsible for this? Actually, it should be the absence of this hormone.
Okay.
Anti-ambulatory hormone. Oh no, that's right. The presence of what hormone? Yeah. Anti-ambulatory hormone. And again, so androgen insensitivity syndrome. Problem is testosterone receptors don't work, so nothing here works. But they do have testes, which still makes the Mullerian inhibitory factor, which does not allow these to be made. So again, this is why AIS and MA patients will present externally the same way, but it's body hair. That's kind of the tip-off. That they never develop the secondary sexual characteristics in AIS. But you got to remove these guys after puberty so that they don't get choriocarcinoma? Some kind of testicular cancer. Okay, and then we also got Kallmann syndrome. Kallmann syndrome is an issue with the migration of certain hypothalamic cells, that they don't migrate properly, which leads to a secondary hypogonadism. So again, it's hypogonadotropic hypogonadism. So these particular areas in the hypothalamus don't migrate to where they need to. So that means there's no gonadotropin-releasing hormone, and in turn, no FSH, no LH, and everything downstream does not get made. So you get this. Decreased TNRH, decreased testosterone. So you're going to have someone with hypogonadism, and the tip-off with this one is that there's anosmia, because the area of the hypothalamus that did not migrate properly is very close to the olfactory senses as well. So that also did not migrate. So someone with ambiguous genitalia, no secondary sex characteristics, and they've got some problems with smelling things. That's your tip-off on that one. And I guess that's it. But I don't know, because with like doing OB and stuff, you get a lot of those kind of questions, like, it's more in the gynecological section where it's like, this girl presents with, she's 16 and she hasn't had her first menstrual period, because like 15 is where you're supposed to investigate. Because if it's like a 13-year-old that shows up and says, all my friends have had their periods, you're supposed to just reassure say come back when you're 15 if you still haven't had your period. Because once 15 happens, you got to be like, okay, something's wrong here. Start looking for body hair or testes or karyotyping or something just to see what's going on.
I had a question. I forget where it was from, but it was asking about what the first sign of puberty would be for a girl. And
Breast bud development.
yeah, got that one wrong.
What is that called? Thecarchy? Thelarchy.
Yeah, that sounds right.
Thelarchy. Yeah. And I only know that because that was a question that I recently got in my stuff. Actually, no, that was PEDS. That's a PEDS question. Because girls' breasts start developing. You start getting the breast, Tanner stage 2, 3, like at 9. And the typical age for menarche is 11. It's breasts first, menarche, then secondary, like hair, and then girl. Because, here's the thing. The reason that menses, some people will say girls shouldn't want to get their period sooner, is that once a girl starts menstruation, that's essentially the end of her growth spurt.
Mm-hmm.
Because, before a woman reaches menarche, she's bundling up all this estrogen. And estrogen is what's helping women's bones grow. It keeps on going. As soon as you ovulate that first time and you release progesterone, it's like you've turned off your growth spurt. So once that happens, women rapidly end their growth cycle. So I don't know if that was you, or how the fuck did I read that? That typically women that have earlier periods tend to be shorter. So there you go.